Welcome back. You're watching McLaren Port Huron's Today's Health, and we're talking about prostate cancer with board-certified urologist Dr. Glenn Betrus. Dr. Betrus, how is prostate cancer diagnosed?
Well, we talked about screening starting with the digital exam and the PSA test. If either of those are abnormal, the next step would be to do an ultrasound of the prostate. That's done in a urologist's office most commonly. That involves a patient lying on their side. A small ultrasound probe is placed into the rectum. Using that probe, we're able to scan the prostate, determine the size of the prostate, look for areas where the echo pattern within the prostate is abnormal. We inject lidocaine around the prostate to do a nerve block, and then we pass a needle into the prostate, typically 12 times, to get 12 different tissue samples. And those are the biopsies that get sent to the lab for analysis.
So that can all happen in one appointment in the office?
It does happen in one appointment, and all in about 15 minutes with minimal discomfort.
So how long does it take then to get the results?
It typically takes about a week or so to get those results. What has prolonged things a bit in recent years is that we're now doing more than just getting the biopsy results. In a lot of instances, we're also doing what we call molecular studies, where they're doing a DNA analysis of the tissue, so that if the biopsies don't show cancer, there are DNA studies that will show us how likely it is that maybe there is an area of cancer that we missed. And if the biopsies do show cancer, there are DNA studies that help us to determine how aggressively the cancer might behave.
And so that takes a little bit longer to process that?
That takes a little bit longer to process that, usually an additional week.
So if you get the diagnosis then of cancer, are there additional tests that the patient needs to have before you make treatment decisions?
So it depends on the situation, but in most cases, no. We used to do routinely a bone scan on all patients who were diagnosed with prostate cancer. We now know that that was significant overkill. And so in low-grade, low-stage prostate cancers, which fortunately is what we usually diagnose, most patients do not require any additional testing. But if the cancer did appear to be more advanced, based on the PSA number and the biopsy results, then we might do a CAT scan and a bone scan, checking for cancer spread to the pelvic lymph nodes and or the bones.
Can you just run through me what are the stages of prostate cancer?
Sure. Broadly speaking, there are 4 stages. Stage 1 would be considered a patient who had a normal digital exam, and the only reason that they were diagnosed with prostate cancer is because the PSA level was elevated. Stage 2 would be a patient who had a palpable abnormality. In other words, they had prostate cancer and it could be palpated on a digital exam, but still confined to the prostate. Stage 3 is when the cancer has grown outside the prostate, but immediately adjacent to the prostate. Stage 4 is when the cancer has spread.
So once you have all of the information from the biopsy, what are the treatment options available for the patient?
So the first thing that we would do is determine the patient's risk. In other words, it would be a risk assessment. And we put patients into categories where they would either be considered low risk, intermediate risk, or high risk. And then rather than a one-size-fits-all, we try to select a treatment option that's best suited for that patient. That treatment option could be radioactive seed implants, freezing the prostate, which is called cryosurgery, external beam radiation treatments, or surgery to remove the prostate, or hormone therapy.
What kind of things get you in low risk, intermediate risk, high risk? The type of cancer?
So it's all prostate cancer, but you're looking at the pathologist's assessment of the cancer. So we do 12 biopsies. How many biopsies show cancer is certainly an important criteria. If you find cancer in 1 in 12 biopsies, obviously that's a better situation than in 10 of 12 biopsies. So that's issue number 1. Issue number 2 is that the pathologist assigns a score to the growth pattern of the cancer, and that score is called the Gleason score. So a score anywhere between 2 and 6 is considered less aggressive. A score of 8 through 10 is considered more aggressive, and a score of 7 is intermediately aggressive. So you take into account the stage, whether it's a stage 1 or 2 or 3 based on the digital exam. You take into account how many biopsies showed cancer, what is the Gleason score, and then if the DNA analysis was done, taking that into account as well.
So it's all prostate cancer, but from what you're telling me, some grow very fast, some grow very slow, and
that's exactly correct. So one of the things that I think the media has done a very effective job on is educating the public that prostate cancer is typically slow growing, and that is a fact. What I think the media has done a poor job of is educating people that more men will die of prostate cancer this year than any other cancer other than lung cancer. So it's almost as if there's two diseases within one. There are the low-grade, low-stage prostate cancers that frankly you don't really have to worry about, and then there are the aggressive prostate cancers that you really have to tackle head-on.
Well, there's so much going on. Which physician specialties is the patient seeing at this time?
So they see, in most cases, a primary care physician who detects that the PSA level is elevated. And then the patient gets referred to the urologist. The urologist is typically the one who does the ultrasound and biopsies of the prostate. If indeed the biopsies confirm the diagnosis of prostate cancer, the patient and the urologist typically sit down and review the biopsy results and also the alternative treatment options. In most instances, I would say that whole process is directed by the urologist, but certainly as a team, if you will, between really the urologist and the patient, and in many cases the patient's family. If the patient was going to choose radiation therapy, the patient would be referred to a radiation oncologist. Sometimes a patient would want to see a medical oncologist for a second opinion.
This is great information. We want to talk a lot more about treatment options, but we're going to take a break first.
Okay.